Hello, this is Will Blakeney, orthopaedic surgeon from Royal Perth Hospital and UWA, giving you this presentation on foot and ankle conditions for medical students. This is what we'll cover: a brief overview of the relevant anatomy, the important questions to ask when taking a targeted history, then some important examination findings that you may have when looking at foot and ankle. Then we'll look at conditions of the ankle and midfoot, hindfoot and forefoot. The bony anatomy of the foot and ankle is quite complex. There are multiple joints, starting from the ankle with the talocrural joint, the articulations between the tibia, fibula, and the talus. Coming further down, the talus then articulates inferiorly with the calcaneus and anteriorly with the navicular. There is also the calcaneocuboid joint. From the hindfoot to the midfoot, we have the navicular cuboid and the three cuneiforms. Moving further forward, we have the tarsometatarsal joint, the 5 metatarsals, and then the phalanges. We'll break the foot up into these different regions to simplify matters. One way of simplifying the foot is to break it up into the medial column and the lateral column. Here you see the medial column on the inside of the foot, which is made up of the talus, navicular, medial cuneiform, and first metatarsal. On the outside of the foot, you have the lateral column, which is made up of the calcaneus, cuboid, and the 4th and 5th metatarsals. The foot is also simplified into regions consisting of the hindfoot, midfoot, and forefoot, which you can see delineated here. The joints between these regions are important, as they're often involved in traumatic injuries. So we have the ankle joint, then the talonavicular and calcaneocuboid joints, then coming forward to the tarsometatarsal joint. It is also important to understand the anatomy of the ligaments around the ankle, as these are also involved in common musculoskeletal presentations. On the lateral side, we have the lateral ligaments, which are made up of 3 separate ligaments: the anterior talofibular ligament, or ATFL, which is the most commonly injured when you sprain your ankle. There is the calcaneofibular ligament and the posterior talofibular ligament, which are involved in more serious ankle sprains. On the medial side, we have the medial collateral ligament, which is known as the deltoid ligament. This is again made up of multiple ligaments, but in contrast to the lateral side, they tend to all join together in a fan-shaped ligament, which is hard to distinguish the different ligaments making it up, but include the posterior tibiotalar part, tibiocalcaneal part, anterior tibiotalar part, and the tibionavicular part. It's also important to refresh your anatomy of the tendons crossing the ankle, as well as the neurovascular structures, but I won't have time to cover them today. Patients with foot and ankle problems often present complaining of pain, swelling, deformity, or impaired function. Pain over a bony prominence or a joint is probably due to some local disorder. Ask the patient to point to the painful spot. Symptoms tend to be well localised to the structures involved. Vague pain across the forefoot, commonly called metatarsalgia, is less specific. It may be associated with uneven loading or muscle fatigue. Often the main complaint is of pressure from the shoe on a toe or joint. Ask the patient if their footwear is restricted. Deformity may be the main complaint. The patient complaining about a crooked toe or a twisted foot, even if it's not painful. Parents will often talk about their children looking flat-footed or pigeon-toed, and older patients may complain about having difficulty finding shoes to fit. Swelling is common, but is more significant if it is unilateral or localized to one area of the foot. Instability of the ankle or episodes of the ankle or foot giving way, previous injury such as a twisted ankle, need to be elicited. Numbness or paresthesia may be felt in all of the toes or in a more circumscribed field served by a single peripheral nerve or nerve root. Asks the patient if their foot pathology stops them doing anything. Does it interfere with their work? Does it cause problems with hobbies, sports, or domestic activities? Again, we have the simple look, feel, move, plus special tests of the orthopaedic examination. Look at the patient as a whole. They should have their whole lower limb uncovered. Look from the front and from behind. The heels are normally in slight valgus, as pictured here, and should invert when a patient stands on his toes, as demonstrated here. This patient on the left has pes planus, or flat feet. The patient on the right has the opposite deformity, or pes cavus, with the heels in varus and an abnormally high longitudinal arch. On the left, you see the typical deformities of a patient with bilateral hallux valgus with overriding toes due to the deformity. On the right, you can see corns on the top of the toes, which are another common presentation. It is, of course, important to examine the patient's gait, particularly the various phases with heel strike, flat foot, and toe off. Gait may be disturbed by pain, muscle weakness, deformity, or stiffness. The position of the ankle is of prime importance. A fixed equinus deformity will result in the heel failing to strike the ground at the beginning of the walking cycle, or sometimes the patient forces heel contact by hyperextending the knee. If the ankle dorsiflexors are weak, such as in a foot drop, the foot may hit the ground prematurely, causing a slap. Then during swing through, the affected leg is lifted higher than usual so that the foot can clear the ground, known as a high stepping gait. Hindfoot or midfoot deformities will interfere with the stance phase. The patient may walk on the inner or outer border of the foot due to pain or avoidance. Toe contact is also important, particularly of the great toe, which may be affected by pain or stiffness in the first MTP joint, preventing normal push-off. The feel part of the examination is important to know your surface anatomy. The regions pictured here are the tendon of tibialis anterior, number 1, the medial malleolus, 2, and then the tendon of tibialis posterior, number 3. On the lateral side of the foot, you have the extensor tendons, pictured as 5, the lateral malleolus, 6, and the peroneal tendons, number 7, curving behind the lateral malleolus. 8 is the transverse metatarsal arch, and 9, the medial longitudinal arch of the foot. Pain in the foot is often localized to the area of pathology. This picture shows you common areas of pain or tenderness and what pathology they are commonly associated with. Stability is assessed by moving the joints across the normal physiological planes and noting any abnormal clunks or movements. Medial and lateral stability are checked by stressing the ankle first in valgus and then in varus. On the left, you see the anteroposterior draw test. The examiner stabilizes the distal tibia with one hand while the other grasps the heel and tries to shift the hind foot forwards and backwards. On the right, you see the talar tilt test. These tests assess the integrity of the ATFL and calcaneofibular ligaments. This first case we will look at will introduce us to some common hindfoot problems which we often see following traumatic injuries. We will also touch on some traumatic midfoot injuries. As you can see here, we have a 22-year-old male who sustains an inversion injury playing soccer. He's able to weight bear after the injury, but it is very painful. The pain is localized to the lateral ankle and there is significant swelling. A simple differential diagnosis would be an ankle sprain or lateral ligament injury, which you see pictured here, a syndesmotic injury, or a fracture. Management of an ankle sprain or lateral ligament injury consists of the common musculoskeletal treatment of RICE, rest, ice, compression, elevation. Patient is normally put in a cam boot initially, and I generally leave them in the cam boot until they are walking pain-free, which may be 2 to 4 weeks for a simple ankle sprain. They can weight bear as tolerated, but some may need crutches initially. It is important to emphasize early range of motion exercises, coming out of the boot for these a few times during the day. Then the most crucial thing is physiotherapy with neuromuscular ankle training. Patients not only damage the ligaments, but they also damage the nerves, and most important, the proprioceptive nerves, which results in them re-spraining the ankle if they are not properly rehabbed. This rehab should involve proprioception, balance, as well as strength training. Strength training of the secondary dynamic ankle stabilizers, such as the peronei, is helpful. A light brace can be worn during vigorous activities that stress the ankle. most patients will settle down with conservative measures alone. A minority of patients may continue, in spite of these measures, to have ongoing mechanical instability with the ankle giving way during everyday activities. In this minority of patients, reconstruction of the lateral ligaments should be considered. This is often combined with an arthroscopic debridement of the impinging tissue within the ankle joint. There are many operations described for stabilisation of the ankle joint. They fall basically into two groups: those that aim to repair or tighten the ligaments, such as the Brostrom procedure pictured on the left, and those that are designed to construct a check rein against the unstable movements, such as the Crispman operation pictured on the right. Here, the peroneus brevis is used as a substitute ligament, acting as a tenodesis to prevent sudden movements inter varus. The obvious disadvantage of the non-anatomical reconstructions is that they sacrifice or partially sacrifice the secondary stabilizers, the peroneal tendons. A syndesmotic injury, sometimes called a high ankle sprain, is an injury of the ligaments between the tibia and fibula. It is associated with a rotational injury. You can see those ligaments pictured here: the anterior inferior tibulofibular ligament, the posterior inferior tibiofibular ligament, as well as the interosseous ligament. Partial tears can be treated conservatively with ankle bracing and physiotherapy. Complete tears are best managed surgically with internal fixation. This may be done with simple screws going from the fibula to the tibia. The patient is then immobilized and non-weight bearing for a period of time. These screws will need to be removed once the ligaments are healed, otherwise they will fracture. Recently, it is becoming more common to use a synthetic type ligament, which you can see pictured here in the middle, a tightrope construct with metal buttons on the outside and a reinforced ligament in between. One advantage of this is that it does not to be removed at a subsequent operation. Examination findings with a syndesmotic injury include a positive squeeze test, which you see here with compression of the mid-tibia and fibula, reproducing pain at the ankle. Patients will also have pain with external rotation and with weight bearing. On X-ray, you will see widening of the space between the tibia and the fibula, or widening between the tibia and the talus. A mesonerve fracture is the eponymous name given for a proximal fibular fracture that occurs with an avulsion fracture of the medial malleolus or rupture of the deltoid ligament, and is associated with a syndesmotic injury. In the X-ray on the left here, you see increased distance between the medial malleolus and the talus, with a small avulsion fracture of the medial malleolus. This should make you suspicious for a syndesmotic injury. You should always palpate the proximal fibula on any twisting ankle injuries and get an X-ray when concerned. Fifth Metatarsal fractures are also common fractures that occur on the lateral side of the foot associated with inversion injuries. We break these up into 3 different types of fracture: an avulsion fracture, a Jones fracture, or a proximal shaft fracture, which is often where we see stress fractures. An avulsion fracture has a fracture proximal to the 4th metatarsal. Treatment is generally conservative with a cam boot or hard-soled shoe, and weight bearing is tolerated. Rarely surgery is required for large displaced intra-articular fragments. The Jones fracture is important not to miss. This area is a watershed region with poor blood flow, which is at high risk of non-union. They should be treated with non-weight bearing with a cast or cam boot for 6 weeks. The majority will still heal with non-operative treatment, but there is a substantial number that will require surgical fixation. In athletes, these are often fixed as they have a high risk of refracture. Pictured here, you see typical appearance of that Jones fracture. Another important injury not to miss, which we will discuss, is the Lis Franck injury, or as we like to call it in Australia, a Lis Franck. This is an injury to the Lis Franck ligament, which is a ligament pictured here, which goes from the 2nd metatarsal base to the medial cuneiform. It is a short and thick ligament on the plantar side. It is of crucial importance as the 2nd metatarsal base is the keystone of the coronal arch of the foot. The 2nd metatarsal base is set into a recess formed by the medial, intermediate and lateral cuneiforms. Transverse ligaments connect the bases of the 4 lateral metatarsals, but none exists between the 1st and 2nd metatarsals. Therefore, the Lis Franck ligament is of heightened importance and of increased risk of injury. X-ray findings may be subtle. It is important to look for widening of the space between the 1st and 2nd metatarsal. Here, a weight-bearing X-ray is important. As you can see on the right, the difference between a non-weight-bearing and a weight-bearing X-ray where the gap increases. Circled on the left, you can see a small avulsion fracture from the base of the 2nd metatarsal and widening of the interspace. If you're concerned and the patient has midfoot pain with a negative X-ray, you should consider an MRI scan. These injuries may also be high energy injuries, which are far less subtle. They often present with extensive soft tissue damage and swelling to the whole foot. Fractures may extend across all metatarsals with gross displacement as pictured here. Initial treatment may be closed reduction plus or minus application of an external fixator with definitive internal fixation once the soft tissues settle down. Surgical fixation may be a simple screw from the medial cuneiform to the base of the 2nd metatarsal, in effect taking the place of the ruptured ligament. There are specifically designed plates which bridge the medial intermediate cuneiform as well as the first and second metatarsals and hold them in position while the ligament heals. Surgical fixation may be as simple as a screw from the medial cuneiform to the base of the second metatarsal, holding them in position while the Lisfranc ligament heals. Bridging plates that are specific for this injury can be used with screws going into the medial and intermediate cuneiform as well as the first and second metatarsal without violating the joint. Fixation may be more complex if the other metatarsals are involved and may use a mixture of foot plates, Lisfranc specific plates and K-wires as pictured in these examples here. We will now move on to some of the more common hindfoot problems. A typical presentation that you may see is a patient complaining of heel pain. Commonly may be due to plantar fasciitis, retrocalcaneal bursitis or Achilles tendonitis. In the elderly, it is important to consider a stress fracture, and in children, a calcaneal apophysitis, eponymously known as Sever's disease, one of the most common causes of heel pain in growing children and adolescents. Achilles tendonitis is an overuse injury of the Achilles tendon, which causes thickening and inflammation of the peritendinous tissue. The condition usually affects the watershed area, which is pictured on the right. It's about 4 centimeters from the insertion of the tendon, and it's an area where the blood supply to the tendon is poorer than elsewhere. The tendon sheath, which is the tissue surrounding the tendon, may become inflamed. Risk factors include increased activity, often seen in athletes that have increased their distance or speed or changed the terrain that they're training on. Can be associated with reduced recovery time, a change in footwear. Can also be associated with flat feet and commonly seen with calf tightness. In a minority of cases, the inflammatory changes appear at the tendon insertion, and there can be associated inflammation of the retrocalcaneal bursa, which is just above the calcaneum and deep to the tendon. This is called retrocalcaneal bursitis and may be associated with a bony change to the posterior part of the calcaneum, which contributes to the pathogenesis. Initial management includes physiotherapy, simple stretching exercises such as what's pictured here. Orthoses, such as a heel lift in the shoe, may improve. Other non-operative treatments such as steroids, iontophoresis have reasonable success, and surgery is indicated in patients that are resistant to conservative treatment. Achilles tendon rupture presents with sudden pain in the heel, primarily in men in their mid-30s to mid-40s, the weekend warriors that return to sport without proper training, but may also be seen in elite athletes. The cause is a forceful dorsiflexion of the ankle. On examination, you see a positive Thompson test. This is what is pictured on the right. A normal test, when the calf is squeezed, you will see plantar flexion of the ankle. When there is no plantar flexion, there is a positive test. Imaging modalities for diagnosis include ultrasound and MRI. Management over the last few years has moved more and more towards non-operative with functional casting and bracing. Surgery is sometimes required. Another commonly seen condition is plantar fasciitis. Interestingly, risk factors include both pes planus, a flat foot, and pes cavus, a high arch. Can be associated with leg length discrepancy. Mostly it is associated with tightness of the Achilles tendon and intrinsic foot muscles. Risk factors include obesity, a sedentary lifestyle, prolonged standing or walking at work, excessive running or a sudden increase in exercise, and poor arch support in the shoes. It may be an overuse injury of the plantar fascia, can present with a heel spur, as seen on the x-ray here, but these are normally a sign of the problem rather than the source of the pain. 95% will resolve with conservative treatment. This includes calf and Achilles stretching, orthotics with arch support, occasionally steroids or iontophoresis, extracorporeal shockwave therapy has had success, and very rarely surgery is required. We will now look at some forefoot problems. Some of the common presentations that we see are hallux valgus, lesser toe deformity, Morton's neuroma, and the rheumatoid foot. Briefly, hallux valgus is a complex deformity of the forefoot, in particular the first ray, as pictured here. It can be treated non-operatively or operatively, depending on the degree of deformity and the symptoms. On the right, you see X-ray pre and post-surgery. Surgery is aimed at correcting the deformity by various described osteotomies. Lesser toe deformities pictured here, hammer toes, floor toes. The patient here suffered from peroneal muscle atrophy, a neurological disorder causing wasting and weakness of the intrinsic muscles, and a cavus feet. On the right, you see a curly toe or an overlapping fifth toe. Operative correction is indicated for pain or difficulty with wearing shoes. Morton's neuroma is another common presentation. It is a compressive neuropathy of the interdigital nerves as they divide at the metatarsal head. Chronic irritation of the nerves as they transverse the metatarsal ligament. It is much more common in women, 9-1. May present with pain radiating into the toes. Paresthesia is present in 40%, and it is most commonly found between the third and fourth metatarsal heads. It may present with a positive Mulder's sign. Here you can see the examiner performing Mulder's test, squeezing the forefoot from lateral to medial while palpating the web space and feeling a click. Imaging modalities include ultrasound and MRI. Initial treatment is conservative. The patient needs to stop wearing high heels and wear shoes with a wide toe box. They may require orthotics. Cortisone injection has good success, and surgical excision is indicated if chronic and not improving with conservative treatment. Thank you for listening. There are many conditions affecting the foot and ankle, and hopefully I've given you an overview of the more common things that you may come across, as well as an overview of how they present and treatment options. If you have any questions, I'm happy to be contacted through my university email.